This is Varun Puri. I am a thoracic surgeon and associate program director of the thoracic surgical program at Barnes Hospital in St. Louis, and serve as an associate professor of surgery at Washington University. Surgery for lung cancer has seen significant developments over the last decade or so. And these have occurred in three predominant domains. The first is access for surgery. Many years ago, most operations for lung cancer were conducted through large incisions. The incision is called a thoracotomy, whereby an incision approximately 6 to 8 inches in length is created on a person's chest. Usually it requires removal of a small portion of a rib to allow the surgeon to be inside the thoracic cavity. And then the operation for lung cancer, which usually involves removal of a part of the lung and the lymph nodes in the surrounding region, is conducted. However, over the last decade, we have used technology from the field of video endoscopy, whereby we have instruments and cameras which are miniaturized and can work through small incisions. And we have applied what's called VATS, or video-assisted thoracoscopic surgery, to this, to the operations we conduct for lung cancer. We make several small incisions on the patient's chest wall, and through these introduce a long video camera and instruments into the patient's chest, and then conduct pretty much the same operation that was conducted through a much larger incision. So that's one minimally invasive way of doing things. The other is robotic thoracic surgery, which is the next generation of minimally invasive surgery. Here, not only are we performing the same operation through small incisions, we are using a hybrid technology whereby man and machine work together to conduct an operation inside a patient's chest and try and improve long-term outcomes as well as short-term outcomes after a major thoracic operation. So that's part A, which is access in terms of doing the operation has become much smaller. Incisions are smaller, patients recover faster, they generally are back to their activities of daily living in a much shorter period of time and end up spending much shorter time in the hospital after these operations. The other is, who can we actually apply these operations to? When you look at historical studies, about 15 to 20 years ago, generally speaking, the average lung cancer patient who underwent an operation was in their 60s and would generally be a somewhat healthy person who could undergo a major operation and withstand the trauma of a big thoracic incision. But with improvements in access, which I just described, as well as better medical care of these patients, many older patients who would previously not have been considered for an operation or considered too high risk for an operation are able to get operations for their early stage cancer, which can be a therapeutic option which is curative. That means can completely cure the cancer in these individuals. The final frontier, which I think surgery is at this point in time tackling and in some ways improving in, is locating lesions in the operating room using virtual technology. Many lesions in the lung can be small and difficult to localize as they're not visible on the surface of the lung. So using a combination of what we call immunofluorescence, or ways in which we can mark the tumor and make it visible by either a robotic platform or using specialized cameras in the operating room, we can find the cancer and find the extent of the cancer in the operating room without having to actually cut into the lung tissue to find the cancer. This helps us in being able to more precisely remove the tumor, try and get the tumor completely out, as well as leave as much lung tissue behind as we possibly can. So this advance has allowed us to perform more precise and localized surgery and improve both lung function in the post-operative period as well as ensure better cancer outcomes.